Well, hello there. Welcome back to Life and Death and Dirt, a death truthful podcast that was supposed to be about also living and gardening, but it's kind of turned into a documentation of my descent into the void. I'm your host, Rosie, and I'm a very depressed hospice nurse. I'm not depressed because I do hospice. I'm depressed because the universe is inherently violent and existence has no meaning. My co-host DJ Lewis is not able to join us today because of internet issues and maybe for some other reasons. So I'm going to do my best to record this episode solo, which is fine because in the end, nothing actually matters. And my therapist has told me that I need to lean into the absurdity of life as to not withdraw my consent from it. So welcome back to Life and Death and Dirt, listeners. Welcome, new listeners. I've been a nurse for 20 years. I've been a hospice nurse for 6 years, and I'm going to talk to you about death and the dying process. I've been lovingly and kindly called out by one of our listeners, Proven Paradox, in that I keep teasing I'm going to talk about the death rattle, and then I keep not doing an episode on it. So fair enough. Yes, I deserved that. And today I am going to explain the death rattle. I also feel like I'd like to explain just in general. Excuse me. Hold on. Excuse me. Sorry, I had to cough. I'd like to explain in general what the dying process looks like for most people. So there's, maybe I should give a trigger warning or a content warning for this episode because I am going to talk somewhat about some, bodily functions and bodily fluids, especially when I'm talking about the death rattle, but also just because if there are people listening who have experienced watching someone that they care about go through the dying process, sometimes this can be triggering or really sensitive for them. So, content warning about today's episode. But if you can, I think you should listen because part of what makes the dying process of one of our loved ones so upsetting, aside from the fact that we are grieving their loss, is the fact that most of us don't understand what's going on or understand what to expect or understand what's considered normal. And so we might see our loved one go through all these different symptoms and processes, and their body's changing and their mind is changing. And that can be really scary and upsetting, especially if you don't know that it's very normal. So there are a lot of things that happen to most people when they are going through the dying process. And what I mean by that is most of us will die because of a disease process. That's how most of us, well, unless we get, okay. Most of us, under normal circumstances and not fascism and nuclear war, will die because of a disease process, meaning we have some kind of illness or disease or condition that over time is going to make our body decline and then till we finally die. Some of us might get lucky and we might die in a snap very, very quickly because something acute happens. So maybe a massive heart attack or like a massive stroke, or like a massive blood clot. Sometimes people are just like living their life, and then they die and everybody's shocked and it wasn't expected. So that's like an acute death caused by some event that happened. Some people will die that way, but the majority, again, outside of fucking end stage capitalism and war and climate change, the majority of people will die because of a disease process. So this would be like, oh, somebody died because they had heart disease, or they had dementia or Alzheimer's, or they died of liver failure or kidney failure. Like that happens kind of over time until you finally take your last breath. So what's interesting about the dying process when people are dying over time because of a disease or condition is that for most humans, regardless of what disease you're dying from, most humans will experience very, very typical expected signs and symptoms as they decline towards death. So I'd like to talk about what that looks like for most people, and that includes the death rattle. So I will talk about the death rattle. Okay. So for a person who is in what we would call the end stage of a disease, or that is like they're close to the end of their life. And this, for hospice purposes, is considered 6 months or less. So hospice, we are heavily regulated by the federal government agency, CMS. Anybody who works for healthcare knows what CMS is. It stands for the Centers for Medicare and Medicaid, Centers for, oh my gosh, what does it mean? Centers for Medicare and Medicaid System. So CMS is like the regulating body that supervises and regulates all certified healthcare in the United States. And for hospice purposes, they give us very, very particular criteria that a person has to meet to even be considered eligible for hospice services. And one of the criteria is that two different doctors have to both agree that this person likely has a prognosis of 6 months or less. So prognosis means likely has 6 months or less to live. And what that means is that even if there's people out there who feel like, oh, I'm done, I want to go on hospice, I've had enough of this disease or this life or whatever you have you. Even if they want to go on hospice, if two doctors don't agree that that person has a 6-month prognosis, that person doesn't qualify for hospice and we can't actually sign them on. So there's actually pretty stringent guidelines. So 6 months or less is kind of the standard for hospice services. And what that usually looks like for most people is when they're in that final phase of their life, they will start experiencing symptoms. I'm going to go through those symptoms in the typical order, meaning like I'll go through the symptoms that people usually experience first, and then the symptoms that they will start experiencing as they get closer and closer to the end of their life. So the first symptom that most people will experience if they are in that end stage of a disease process is fatigue. This is across the board, regardless of what disease process somebody has, they will very likely start experiencing more fatigue. So meaning they require more sleep, or they require more rest, or they are not able to do as much as they once were able to do. So maybe they were getting up and walking out to get their mail every day, and now that's too exhausting, and that really takes it out of them to do that. And then after they do get their mail, they need to sit down and rest and recover for a while. So increased fatigue, increased sleep, and increased need for rest and recovery. Very normal. This is across the board. Most people experience this, especially people with cancer diagnosis. That is the first symptom that people say. They say, I'm exhausted. That's very typical. Okay. So the next symptom that a lot of people will experience is something that we call withdraw, or I call it like socially detaching. Very common, very normal, and some would argue necessary. So a lot of people, as they're getting closer to the end of their life, will start to withdraw from society or from what's happening around them. So they're not as excited to engage in some of the activities that they once engaged in, or they get kind of apathetic sometimes about daily life or visitors. Not to say that they don't love and enjoy seeing those visitors, but it's just that they literally don't necessarily have the energy to engage with people like they once did. So they might stop coming to the breakfast table every morning. Now they just would prefer you to bring breakfast to them in their room. Or maybe like their every Tuesday poker night, they stopped going to that. They're just not really interested in it. Or maybe they seem less enthusiastic about choices, like, oh, Grandpa, do you want roast beef or fried chicken tonight? I don't care. Okay, so they're kind of like withdrawing socially and detaching from this life. So for people like me who are much less into psychosocial side of things, or the spiritual side of things, I should say, I feel like, well, maybe it's just because they're so exhausted and they're just tired. It's too much energy to make decisions. It's too much energy to play poker. And then some people who are much more interested in like the spiritual aspect of things might say, Well, it's also necessary and important for them to detach from this life in preparation for letting go, or in preparation for wherever it is they're going to go next. Either way, very normal. So if this happens, please don't take it personal. If you try to call grandma or you try to call your mom or dad and, oh, they're just too tired to talk to you on the phone, don't take it personal. It's very, very normal and a very expected thing that they would detach like that. It doesn't mean that they love you any less or that they're sad or upset that you called. It's just part of the process. The next thing that we see, very, very common, I would say almost across the board. And this one, families and loved ones struggle with so much. So, a person at the end of life who's in the end stage of a disease process will lose their appetite. And that's normal and it's okay. So, regardless of regardless of whatever disease process a person is dying from, their body knows on some level, on some physiological level, their body knows that it's dying and it will start preparing to die. There's a hospice nurse, her name's Hospice Nurse Julie on TikTok, and she does a great job of explaining like death and dying education and end of life education to people. And she says all the time, our bodies know how to die. Like it is wired into our DNA to hopefully survive birth, which those of us who are here have. Most of us do, but not everyone. So hopefully survive birth is one thing that our bodies know how to do, and then how to die is one thing our bodies know how to do, and then arguably our bodies know how to reproduce. Like the three main things that go through the process of life from beginning to end. So she says our bodies know how to die, and when our bodies realize they're dying, they will start doing things on purpose, and we don't even have to think about it. So one of those things is that our appetite goes away. There's several reasons for this. Number one, if our body realizes that it's time to prepare to die, our body is not going to be putting energy into regenerating cells like we normally would. Our body knows it doesn't need to regrow muscle cells. It doesn't need to regrow skin cells. It doesn't need to try to regrow or regenerate liver cells. It knows that. It knows it's time for all of these organs to shut down. So one, we don't need the energy to try to regrow cells. Number two, the process of eating food, digesting that food, and metabolizing that food takes a ton of our energy. We don't think about it because we're pretty healthy. And so we feel hungry, we eat, and our body processes that food and gives us energy. But that process takes a lot of our energy that we have in our body. So it takes a ton of blood flow to our whole digestive tract. It takes a ton of time to like absorb and metabolize the nutrients from those foods, and then push the rest through our digestive tract. So that takes a lot of energy. And if our body realizes it's dying, it will shunt energy away from what it considers the non-essential organs, and then redirect that energy toward the organs it deems essential. Our essential organs are our brain, our heart, and our lungs. I mean, in the end, those are the three essential organs that our body is going to try to shunt and redirect energy to. And it will slow down the energy that it is directing towards our digestive tract, which takes a ton of energy. Our kidneys, that's why our kidneys shut down at end of life. Or if you've ever known somebody who is really, really sick and they experience acute kidney failure because of that illness, it's because the body realizes it needs to shunt energy away from the kidneys to the other important organs, what it considers important. So digestive tract, kidneys, liver, our skin, our muscles kind of waste away. Very, very normal part of this process. Okay. So decreased appetite is normal. Our body's doing it on purpose. Our body is shunting energy and blood flow and circulation away from the digestive tract. There's also some diseases that actually will decrease your appetite, specifically cancer. So cancer tumors secrete chemicals and hormones into our bloodstream that make our appetite go away. This is why cancer is so insidious and such a nasty disease for so many reasons. But it literally secretes chemicals into the bloodstream of a person who has cancer that makes them not want to eat. So if you have a loved one who is going through the dying process and their appetite is decreasing, it's okay. Their appetite is decreasing for many, many reasons. And it's not like us healthy living people. When we skip several meals, we will feel uncomfortable. We'll feel hungry and irritable, and that's uncomfortable to us. But a person who's dying doesn't have that same response to skipping meals. And like I said, their body's doing it on purpose. Now, what I do see though, like I mentioned before I started on this tangent, um, loved ones. This is the number one thing I see loved ones struggle with when they are trying to care for a dying person. We as humans, we hate it when the people we care about don't eat. It is in our DNA to feed each other and especially to feed the people that we care about. So it is like on a biological level, when we see our loved ones not eating, it can actually be a major struggle and very, very distressing to us. Um, if you think about it, like we don't like it when our friends don't eat, like if they're going through something and we're like, did you eat today? Okay. Like we don't like it when our friends don't eat. We don't like it when oh my gosh, when our kids don't eat and our babies don't eat, we lose our freaking minds over that. We can't stand it. We can't even stand it when our pets don't eat, right? Like you notice when your dog, like, oh, lady didn't eat her food this morning. What's going on? Like this is ingrained in us to feed the people and the animals that we care about. So it can be very difficult for loved ones to handle when their dying person stops eating or decreases in appetite. And what I see, unfortunately, sometimes, and I know it's out of love, it's not malicious, but I see families like really like, you got to eat, here, eat. And they're like almost forcing their loved one to eat. And I know they think that they're caring for that person, but actually that can be worse than if you just allow a dying person to not eat if they don't want to. Um, and honestly, if the dying body has shunted all this blood flow and circulation away from the digestive tract, and we're like, eat, and they finally are like, fine, and they'll eat just to get us to be quiet, because that happens. Now they've got all this food in their stomach that's just sitting there like a rock because their digestion has slowed down. So that's actually can be really uncomfortable for people. I know we've all experienced that where we eat something and we're like, oh God, it's just kind of sitting there in my stomach. That's not comfortable. You can feel nauseated and bloated, and a dying person can also experience that. So, what I want you to take away from this ramble is if you're caring for a dying person and they don't want to eat, don't force them to eat. Now, of course, we always offer, but we never force. That's what we say. Always offer, never force. And if they request something, give it to them. Honestly, especially if they're like at the end of their life and they say, all I want to eat is ice cream for all 3 meals. The hospice nurse will say, okay, what flavor? That's fine. Like you're not eating because you're trying to bulk up or get the gains in the gym. Like you're eating for pleasure at this point. Something else that's kind of interesting that happens, and I think it's kind of sweet. It's endearing in a way, is that we'll have people who are on hospice, they're going through the dying process, and they might request a specific meal, or I've seen them sometimes request like kind of really involved meals, like, oh, I really want roast beef, and then I want green bean casserole, and I want mashed potatoes with brown gravy, and I want this, and they'll make this big order of some delicious meal that they'd like to eat. And their loved ones usually are like, okay, I'll make you whatever you want. And then their loved one slaves away for this meal, brings it to the dying person, and the dying person takes one bite, like one bite of the potatoes, or just smells it and then sits it there and says, okay, I'm going to eat that in a minute. And then they fall asleep. Okay. Not uncommon. I see this. And I think it's kind of sweet and cute, even though it can be frustrating for the person who's trying to feed the dying person. But I've seen that happen multiple times. A dying person kind of ordering this big, elaborate meal that they want. The family's so excited that their loved one is about to eat, and then they don't. It just sits on their bedside table. But the fact that it's there and they got to smell it and they got to see it is enough for some patients. Okay, so we've talked about fatigue, very normal, very expected. We've talked about withdrawal or socially detaching, very normal, very expected. Decreased appetite, I'd say almost 100%, every single patient. Very, very normal, very expected. Nothing that we need to distress ourselves over. Okay. Another symptom that we will see is a person will get weaker and weaker. And ultimately, most people will end up either chair bound or bed bound, where they really, their body is too weak to be able to get up and walk around independently, or even just to be able to get up and stand and turn and go sit in a different chair independently. Now, at this point, I've gone through some of the earlier symptoms, and now we're getting into the symptoms where a person is progressively getting closer and closer to the end of their life. So chair bound or bed bound is not uncommon. I would expect to see that at least at some point for most people going through the dying process. We also see people lose control of their bowels and bladders. Very, very normal. Some people lose control a lot earlier than other people, but at some point I would expect that would happen. That's, again, like our neurological system, which is ultimately what controls our bowels and bladder, is shutting down, and I would expect to see that happen. So this is where your hospice team can be very helpful in helping you manage that and continue to have your dignity. There's lots of different options for people who are having bowel and bladder control challenges. So that's where I want you to reach out to the professionals to teach you how to handle this and how to maintain the dignity and comfort of your loved one. Okay, so now we're continuing to progress. At this point, we've got somebody who most likely is either in bed or a chair. Recliner, like lazy boy recliner chairs, are a fan favorite. A lot of people spend a lot of time in those, and even will start to just live in those and sleep in those chairs. And that's perfectly fine. If that's where they want to be and that's where they're comfortable, let them. That's fine. I've taken care of lots of patients in a recliner chair. And that's where they like to be. Especially, I've noticed, especially people who have lung diseases like COPD and emphysema. Those patients love their recliners, and I'm happy that they're in their recliner too. So now we're getting to a point where a person is probably sleeping most of the day or a lot. They're probably not eating a whole lot. They're spending a lot or all of their time in a bed or a chair. And they may need comfort medication. So I've talked about morphine in another episode. That's not the only medication that we use to provide comfort for people who are going through the dying process, but it is the gold standard. And there's a few reasons for that. Number one, it's cheap, period. It's cheap on the pharmaceutical side of things. Number two, it's readily available for now. DJ and I had a conversation about, there's opium fields that the US certainly controls in its own way, and that's how we get our morphine. And for now, it's readily available, but who knows what's going to happen on a global scale or on a climate change scale. I anticipate that if we continue on the trajectory that we're on, we're going to transition over into using fentanyl, because that can be synthetically formed over morphine. And we already can use fentanyl for people if we need to, but morphine's the gold standard. So it's cheap, it's readily available, it's great for pain for most people, as long as they don't have an allergy to it or can't tolerate it. And it's also excellent for relieving shortness of breath. So pain is one thing. That's like when you go to the doctor and they say, oh, do you have any pain today? Oh, you do. 0 to 10, what's your number? Like, that's something that we are forced to collect that data by CMS, that government agency that I talked about. But a lot of people forget to ask about breathlessness. or shortness of breath. So pain is one thing, but you can also be very short of breath or like feel like you've lost your breath and you're not necessarily in pain. A lot of people don't describe that as painful, but that's extremely distressing. And so that's a symptom that we can utilize morphine for to alleviate that breathlessness or that shortness of breath. And I've had several patients who they don't have any pain per se. They always say like, no, I don't have any pain. I just can't breathe. And we can utilize morphine for them just for their breathing alone. They don't have to even have any pain at all for us to justify utilizing morphine to alleviate their shortness of breath. So that's our gold standard. We have other medications that we can use. And then we have other medications that maybe aren't necessarily pain medications that we can use. Like if somebody has anxiety or they can't sleep or they're nauseated. So we've got a whole arsenal of medications we can use. Most people do need some form of comfort medication, but not everybody does. So we all die for different reasons. We all die of different disease processes. And not every single disease process is necessarily painful. But a lot of them are, or a lot of them do have at least some element of discomfort associated with them. So your hospice team or whoever it is that's caring for you should be aware of what your symptoms are or what your loved one's symptoms are and respond accordingly for that particular person. As far as we know, the actual act of dying is not uncomfortable. It's not inherently painful just to die. But the diseases or the reasons we die can cause pain or discomfort. So not everyone needs lots of pain medication, but some people do. And some people need a little bit of pain medication or comfort medication, and that's fine. And we can utilize those appropriately. This is where I say I think hospice has the expertise in this realm is end of life relief of discomfort. So let's revisit our patient now. So our patient has gone through, they've had a lot of fatigue, they need more rest, they're socially detaching, they're not as excited about eating or maybe not eating a whole lot at all, probably needing more help with moving and ambulating, excuse me, moving and walking, or even at this point is chair-bound or bed-bound, probably having some issues with bowel or bladder control. And then, usually people, they'll stop eating, but they'll still want to drink. They'll still be able to take in fluids. So this is perfectly fine, and we encourage that as long as the person wants the fluids and as long as they aren't choking on those fluids. So another symptom that's not uncommon, and now we're getting quite close to end of life, is that we will lose the ability to control the mechanism of swallowing. Or to control the muscles that it takes to swallow. So really, if you've ever studied swallowing, which I imagine most of you have not, because that doesn't sound exciting, but I have. It is a very intricate process, and there's all these teeny tiny anatomical parts in our mouth and throat, and they all have to work together in exactly the right timing. And I mean, we're talking down to fractions of seconds for us to swallow appropriately or to swallow successfully. The human body is actually designed terribly. I know that a lot of Christians say like, oh, we're perfectly designed, but actually we are a terrible design, because what design would have one tube that starts at your mouth, but then splits into two different tubes? And it's supposed to be one tube for food and water, and then the other tube right next to it is for your breathing. Like, that's a horrible design. That's very stupid, but that's how we have evolved. So in order for us to swallow safely and appropriately, it takes a lot of very intricate, perfectly timed mechanisms in our throat. And as we're getting close to the end of life, we lose the ability to control the swallowing, or it's delayed, or it slows down. And so a lot of people will have a lot more difficulty swallowing food, fluids, medications, or even every time they try, they might choke or cough. Okay. That is not uncommon. I would expect to see that at some point during the dying process. Again, usually when we're getting quite close to the end of someone's life. So at this point, this is where we say, please do not feed your loved one unless they specifically ask for it. And we have very special ways we need to feed people if they have a lot of choking when they're swallowing. Your hospice team should talk you through that. This is also the point where we would try to make sure that we're using any kind of medications. If the person needs medications, we would try to use topical medications, so like patches or gels or creams, or medications that can just be slipped under the tongue or in the side of the cheek and absorbed there, because it's not uncommon that people lose their ability to swallow. So we're prepared for that and we can handle that. That's where your hospice team can be the experts and guide you through this part. Okay. So let's visualize our person. Most likely they're in bed or in their recliner, like lying down, or maybe their head's elevated a bit. They're having difficulty swallowing. They probably aren't awake too much. They're probably spending a lot more time asleep or appearing to rest. Now I'm going to start talking about the death rattle. So, content warning for people who have seen a loved one have a death rattle. In my work in hospice, when I'm talking to people who have witnessed the death of a loved one going through the dying process like this, if there's something about that death or a memory that they have about that death that was distressing or upsetting, the number one thing people bring up is the death rattle. This is the number one thing that I feel people kind of take away some trauma from the dying process, is if they witness their loved one having a death rattle. Excuse me one second. I hear people mention things like, oh my gosh, the sound was horrible. He drowned in his own fluids. Like, it sounded like he was drowning, gasping for breath. And it can sound like that. But I want to explain what's actually happening and hopefully alleviate some of this trauma that people have surrounding witnessing a death rattle. So when a person is dying, they go through all these symptoms that I've already talked about, and it's very normal and expected that we would see them get to a point where they are what we would call minimally responsive or even unresponsive. So they're still alive, their heart is beating, they're still breathing, but they're not necessarily, they're clearly either lying down or in their recliner chair at this point, and they're not necessarily responding to us if we try to talk to them, or if we say, oh, can you lift up your hand or squeeze my hand? Maybe they don't respond, or maybe they kind of do, or when you talk to them, they might kind of flutter their eyes or look over at you, but you can tell they're really, really kind of detaching, like their body is shutting down. It almost looks like a coma, or like like a half coma. So what happens in the human body? Okay, content warning, I'm going to talk about bodily functions and bodily fluids. Hang in there. So for those of us who are not dying, our body, our mouth and throat constantly makes saliva and secretions 24 hours a day. And that's normal, and that's supposed to be there because our mouth and throat need to stay moist for many, many reasons. So our body is making saliva in our mouth and throat, and all we do is swallow it, and we don't even think about it all day. Except for right now. I bet all of us just swallowed. We all just thought about it. Okay. But otherwise, like, our mouth is making saliva, we swallow it all day and all night. We don't even think about it. That's normal. Now, when a person is dying, let's imagine this person, all the things I just talked about. This person is at this point lying down. This person is not swallowing anymore. They've lost the ability to control their swallow. They're minimally responsive. Okay, so even though those things are happening, their body is still making saliva in the mouth and the throat. So if a person is lying down, and their body's making saliva, but they're not swallowing it like we normally would, what happens to that saliva? It pools in the back of the throat. And as that person is breathing, their breath goes back and forth through this wet. And that makes these gurgly, rattling sounds. And that's what the death rattle is. It's not that person's lungs filling up with fluid. It can sound like that because sometimes people, depending on their anatomy or how hard they're breathing or how much secretions is in the back of their throat, it can be really loud and really sound gurgly, almost like when you put a straw in milk and you blow bubbles into it. Like, it can sound really significant, but it's not their lungs filling up with fluid. That can happen. That's a different thing, but that's much less common. So death rattle is much more common, and all it is spit in the back of the throat and a person's breath going back and forth through that spit. That's all it is. Our best science so far indicates that the person experiencing the death rattle, as long as they seem comfortable and there's other signs and symptoms we can look for that indicate they are comfortable, is not necessarily suffering from experiencing that death rattle. Our best science indicates that actually it's much worse for us to listen to it than it is for the person experiencing it. Most people will have at least some sort of a death rattle, but not every single person. It's not like, oh, well, this has to happen and then you're going to take your last breath. But it's not uncommon. And again, some people just have like a little rattly sounds. Other people have a very pronounced death rattle where it's really loud, and anything in between. So the death rattle, again, kind of gurgly, wet, rattling, I guess, sound that people can make. And it's just because their breath is passing back and forth through a collection of saliva in the back of their throat. What can we do for the death rattle? And normally when somebody is at this point, we're talking they have like maybe 24 hours before they die. This is very end of life. And that's part of why it has this scary, spooky name. Oh, the death rattle. Because it's like, once you hear that, it's the harbinger of their death. That's going to be any minute, So actually the medical terminology for the death rattle is terminal secretions, which is much less scary and seems a little more sanitized, I guess. But yeah, usually we're hearing this at very, very close to end of life. So what can we do about the death rattle? Depends on who you ask. Because this is my podcast, I'm going to tell you the gospel according to Rosie. So my number one medication that I want people to have if I feel like they're experiencing discomfort, if they can tolerate it and they're not allergic, is morphine. So if I have somebody who's experiencing a death rattle that's significant enough that we feel like we want to do something about it, then my first medication I would suggest is utilizing morphine. One, to make sure that that person's not in pain, even if they can't tell us. Two, to help decrease any shortness of breath they could be experiencing. Again, we don't necessarily know if they're uncomfortable, but I don't think it hurts to ensure that they're comfortable. Morphine also has a mechanism that it helps slow down and relax the mechanism of breathing as well. So I think that's an added benefit in utilizing it for the death rattle. So I prefer to utilize morphine, and then positioning, like literally helping move that person around either in their recliner chair or their bed. So propping them up with pillows, or if they have a hospital bed or an adjustable bed, we'll prop the head of the bed up. Or if they're in a recliner chair, prop the head up and help to move some of those secretions around. You can also do what's called kind of some postural drainage, and that's where you, on purpose, lie someone flat, turn them on their side, or even lie them with their head down a little bit, help the saliva come out of their mouth, wipe it away, and then reposition them back in a more comfortable position. So I know that sounds old school, but that's actually what I prefer in my work. There are other medications that we can use, and some nurses and some doctors are much more They use them much quicker than I necessarily would, but we do have medications we can use to help dry up the saliva and the secretions. Okay, yes, that can help dry up the secretions in some people, but those medications also dry up the person's mouth, their eyes, their genitals, their skin. It makes their heart race. Like it's kind of like an upper. If you imagine, if you've ever, for people who know what I'm talking about, like you get kind of dried out and your heart races. So yes, we have those medications and we can use them to dry up the secretions, but let's weigh the like cost benefit here for the person. Is it more comfortable for them to be all dried out and have their heart racing? Or is it going to be more comfortable if we just try to reposition them and make sure that, you know, their pain and breathlessness is taken care of? Either or. So that's my personal take on it. I'm not really quick to jump at these drying agents, although they can work and a lot of people use them. I would hope for maybe, if needed, just some combination of the three. I would usually go for morphine or some kind of, you know, comfort medication, repositioning, and then maybe use the drying agent if it's needed. So that's it. That's the death rattle. It's when you break it down like that, I hope it's less scary or less traumatizing for people to hear about that. It's just spit in the back of our throat. And like I mentioned, some people, not every single person has like a true death rattle, and some people have a little bit of one, some people have a very pronounced death rattle. I took care of a person who had been an opera singer, so naturally their death rattle was very loud because they just had like what you would call a set of pipes, like their throat and their airway was you know, trained as an opera professional, and so they had lots of room in their throat and their breath was going back and forth through their, you know, through the secretions. And so, you know, we did what we needed to do to care for that person. But again, they didn't appear to be in any discomfort or distress. It was just really hard for us, including the loved ones, to hear that because it can sound really scary and it can sound really distressing. But again, the death rattle is not your loved one drowning on their own fluids. I know it sounds like it, but it's not. That's not what's happening. I feel like I need to take a breath. So that's the death rattle. I hope that demystified it somewhat for you. I hope that if there's people out there who are holding on to trauma from experiencing that or witnessing that, I hope I've alleviated some of that moral distress for you. Okay, so moving on. You know, now I said if somebody is experiencing a death rattle and they're in this less responsive or even unresponsive state, they're very close to the end of their life. So at this point, from now until final breath, I would expect the person to become more and more unresponsive if they're not already completely unresponsive. We would expect that their breathing patterns would change. A lot of people will have what we call Cheney-Stokes breathing patterns. You don't need to worry about what that is, but it's just that our breathing pattern changes. Something else that's interesting that happens is people can have temperature changes very close to the end of their life, where you check their temperature and they have quote unquote a fever. So their temperature's very elevated. And for those of us who are not dying, when we see an elevated temperature, we think, oh no, infection. Okay, that's what that indicates for most of us. Now, in a dying person, sometimes people can have a fever because they have an infection. Maybe that's part of the dying process for them. But a lot of people can have an elevated temperature at end of life and they don't have an infection. All it is that the part of their brain that is responsible for regulating their core temperature is shutting down. Like it's misfiring. Again, because as we die, the process of dying is just that our organs are shutting down. And so it's kind of interesting that you'll see people, you know, oh my gosh, their temperature's 101, but they don't have an infection. It's just because their brain's shutting down, and our brain is what controls all of our bodily functions and our metabolic functions. So if people have a fever at the end of life, unless it seems like it's bothering them, we don't do a whole lot about it. We don't feel like we need to go and rip their sheets off and rip their blankets off and try to give them Tylenol. We can, but if it's not bothering them, don't do anything. Like the less we are involved in the dying process, the better for that person in most cases, because like I mentioned before, our bodies know how to die and we don't want to mess with that. Okay. We do want to intervene if somebody's uncomfortable. That's what we're here for. And that's what our modern science and understanding is here to help with. However, we don't need to go in and address every single symptom that somebody has if it's not bothering them. That's the key. So end of life fever, kind of interesting phenomenon that does happen. Also at this point, this person is most likely not taking in any fluids, okay? Because they've lost their ability to swallow or they've lost their drive or their thirst drive. Very normal, very, very normal. Our body, because it knows how to die and it knows how to prepare us for death, will dehydrate itself on purpose. This is normal and this is merciful, okay? Our bodies will purposefully dehydrate as we get very close to end of life, and there's a reason for that. Number one, we've already lost our ability to swallow, or we're getting close to it. Number two, if our organs are shutting down and we have all this fluid on board and we're super hydrated or overhydrated, and our poor heart that's trying to shut down is pumping all this fluid and trying to pump all this fluid around our body. That is way, way too much for our heart to handle at that point. And so what happens is the heart is tired and it's weak and it has all this fluid it's trying to pump and it can't pump it. And so that fluid backs up into our lungs. And then we get short of breath. So being hydrated at end of life can actually be more distressing than if we permit people to be dehydrated, which is what their body's doing on purpose. This is why, if you've ever had a loved one on hospice, they usually don't do IV fluids for people. Usually. Sometimes they can in different scenarios, but for the most part, we do not hook people up to IVs to rehydrate them. And that can be hard for a lot of people to understand that concept until they learn what I'm telling you now. Because anytime you're sick and you go to the ER, what's the first fucking thing they do? They throw an IV in your arm and they hook you up to fluids, right? Like that's our Band-Aid for everybody. I used to be an ER nurse. Everybody got fluids, okay? Except for people with heart failure. But for the most part, as soon as you go in the ER, they put in an IV, they draw blood to test labs, and then they hook you up to fluids. So for a lot of us, we have that in our mind, like, oh, if you're dehydrated, you got to go get an IV and get fluids. Yes, if you're healthy, or yes, if you're alive. But in a dying person, hooking them up to a bunch of fluids is actually going to make things much more uncomfortable for them because their body can't handle those fluids, which is why their body was purposefully dehydrating itself. So hospice nurse Julie, who I mentioned before, she says, we like to die dry. Like our bodies want to die dry. So don't feel like you need to be forcing fluids into a dying person. In fact, please don't do that. What we can do is we can make sure that we are giving lots of really good oral care. Okay, so making sure their mouth isn't all dried out. We have different little swabbies and sponges and things like that that we can use to make sure that we're cleaning their mouth and moistening their mouth. I am a freaking chapstick fiend. Some of you who know me know that. I've got one right here. So I moisten mouth, clean mouth, and then I'm putting lip balm and chapstick on everyone, okay, even if they're unresponsive. So don't feel like you need to rehydrate a dying person. In fact, please don't do that, okay? So now we've got a person who is minimally responsive or unresponsive. They're bedbound. Their respirations are changing. They may have experienced a death rattle. They're dehydrated, normal. They could have temperature changes, a fever, or sometimes their temperature goes lower. Again, that's just because the parts of the brain that are in charge of controlling body temperature are misfiring and shutting down. And then finally, sometimes we'll see people turn colors, and that's okay as long as it's not hurting them. A lot of people will have some amount of dusky color. We call it cyanosis. That's just when people are kind of turning like a little dusky or purpley or blue. Unfortunately, that's normal. It's not hurting them. It's just hard for us to see. Some people will have what we call mottling, and that is like MOTT, mottling, ELING. And that's where they can kind of, especially on their extremities, especially their legs and their lower extremities, you might see this kind of purpley, like spider web looking splotchy coloring to their skin. Very normal. It's not hurting them. It's just a part of the process. Like their circulatory system is shutting down, their skin is shutting down. The skin is an organ and it can shut down and fail, just like other organs can experience organ failure. And then at this point, we would recommend that the family continue to utilize comfort medications like they have been, even if the person's unable to tell us or show us if they're uncomfortable. And also, we always educate loved ones to speak as if their loved one can still hear them, even if the dying person is unresponsive. Even if the dying person's eyes are rolled back in their head, which is normal, we see this, okay, and they don't seem like they're moving or responding at all. We still tell people always speak to your loved one as though they can hear you. Some of you may have heard, I told a story about a patient who I called Sheila on a podcast. It was Into the Abyss. It was Drew and DJ's podcast previously, like a couple years ago. And Sheila was a patient who I had who appeared unresponsive, but I was talking to her and then she started responding to me. She started nodding her head and then shaking her head at me very appropriately to questions that I was asking her. And that to me, I mean, I did believe that people can still hear you, but that was me literally experiencing it. That I had a person who I thought was totally unresponsive, but clearly she heard me, understood what I was asking, and was able to even answer me. And then she died hours later. Like this, it turns out I was talking to her just hours before her death. So, dying person who appears unresponsive, all we need to do for that person is make sure they're safe, make sure they're clean and comfortable, and then we allow them to die. And this is the hardest part for most people because all our lives, in the whole rest of the medical community, in the whole rest of our lives, even if we're not medical professionals, we want to take care of people and make them feel better. And the concept of not doing anything, especially when we can tell somebody's about to die, is really, really difficult for a lot of us to handle because we just feel like we need to do something. So we don't. We don't need to do anything more for that person. If we've made sure they're safe, they're clean, they're comfortable, we just allow their body to go through this process until they finally take their last breath. What we can do is we can sit with them, we can play their favorite music, we can try to make the room really comfortable. Some people turn down the bright lights, turn on a nice little side lamp, turn on the music, make sure their beloved pets are there with them if that's appropriate, if that can happen. And just tell them what your favorite memories are of them, or tell them that your family is going to make sure that everyone's okay, everyone's going to be taken care of. This is a big one. um, you know, you see it in the movies all the time. This is one thing the movies get right about medicine and the dying process. The only thing they get right is that they say you need to tell them it's okay to go. Or some of you have probably experienced this. Like you feel like you need to tell them it's okay for you to go. And this is real. This is a real thing. And a lot of people, that is a heartbreaking sentence to have to say out loud. And as soon as they try to say it out loud, they start crying, and that's normal. Okay. So a lot of people know that they need to tell their dying loved one, it's okay for you to go. But sometimes saying that feels impossible. So there's other ways that I encourage people to say that. And one of my favorite ways is I say, you don't have to tell them it's okay to go, but you can tell them you understand that they have to go. Okay. Like give them that permission. I understand you have to go, even though maybe you don't want to go. I don't want you to go, but I understand you have to. Okay. Um, or I say, tell them that everyone here, all the loved ones, will all take care of each other. Tell them that. Say, it's going to be okay. We're all going to take care of each other, especially with matriarchs of families. This one, I see these matriarchs, these grandmothers or mothers, and they need to hear everyone's going to take care of each other. We will take care of each other, and we're all going to be okay. They need to hear that to let go. And that also just um, is evidence that yes, people can still hear even if they're unresponsive, because sometimes they wait for those words. In the last episode, DJ and I talked about some other unexplained death phenomenon, which is kind of interesting, like seeing visions or waiting for loved ones to leave the room before they take their final breath, or waiting for that one final visitor to come and visit. So if you haven't listened to that episode and that sounds interesting, it was just our last episode we talked about that. Okay, so we've gone through this journey with a dying person. We're all the way up to the point where they seem unresponsive and almost comatose. And as long as they're comfortable and safe, we don't do anything else. We allow their body to die. And people will come to a point where they will take their final breath. This can happen in in different ways. Sometimes people will start to kind of like pant and have like really short, rapid breaths, and they just kind of, and that's it. That's their final breath. Other people will have periods of apnea. So apnea just means they stop breathing, like sleep apnea. You stop breathing in your sleep. So some people they'll take a breath and then they stop and have a long pause. And then they'll take another breath and then have a long pause. And sometimes these pauses in between breaths can be like 1 to 2 minutes long. And when you are sitting there looking at your loved one, wondering if they just took their last breath, 1 to 2 minutes feels like an eternity. Like that is a long time, but it can be that long. And then sometimes after 2 minutes, they'll take another breath. Okay. That's okay. As long as it doesn't seem distressing to them, which most likely it doesn't. That's just one of the breathing patterns that we can see at the very end of life. I mean, imminent death. Okay. So some people will take a breath, long pause, take a breath, long pause, and those pauses just get longer and longer until they don't take another breath. Some people will kind of have a sigh where they just kind of go, ugh, and that's their last breath, which I think is kind of sweet. I mean, bless them for that. Like, it's just that final sigh of like, oh, all right, this is over, anything in between. So, we all take our last breath in different ways. None of them are right or wrong. When we tell people, if we have somebody on hospice and we feel like, okay, this patient is getting very close to end of life, we educate the family about those breathing patterns. And we say, if you feel like your loved one has taken their last breath, wait 5 minutes and then give us a call. Just in case there's going to be another couple breaths in there. We do tell them to wait a little bit before they call us. And then once they do call us, the hospice team, one of our hospice nurses goes out and pronounces that patient's death. So when someone's on hospice, they do not need to call 911. In fact, we don't want them to call 911. They don't have to call the police. They don't have to call the coroner. They don't have to call anyone. They just call their hospice team, and the nurse comes out and takes care of what needs to happen right in that moment. So I've been that nurse many times where I've had to go out and pronounce death. And it's usually much, much less chaotic and stressful than if we're calling the police and lights and sirens are showing up and the neighbors are looking out and wondering what's going on. We don't need that. So on hospice, when a person dies, The family calls the hospice nurse and they go out to be with the family during that time and pronounce death. And that can be any time. I mean, that's 24/7, like weekends, middle of the night, Christmas morning. I had to go out and pronounce, at like 1 a.m., anytime. It doesn't matter. Okay. After someone dies on hospice services, that family can then utilize the bereavement and grief support that's offered by hospice services. And this is something that is required for any Medicare certified hospice, which are going to be like the legit ones. They have to offer bereavement services and grief support. So if you have experienced that, please don't hesitate to reach out and see if there's some bereavement support or grief support that you can utilize. Not everybody wants to utilize it or feels like they need it, but it can be very beneficial for many grieving loved ones. It's normal to grieve. You're supposed to grieve. Like, this is normal. You are supposed to be affected in some way by the death of somebody that you cared about. And our society expects you to immediately, if you're lucky, you get what, like 5 days bereavement from your work. If you're lucky, maybe you get 1 or 2. A lot of people don't get any. You're supposed to just, put your vest back on and go back to work, which is disgusting, but that's our society. But it's very, very normal for you to need a grieving time. And for that grief to last for the rest of your life, it just morphs, it changes, and you grow around it and you learn how to manage it for the most part, but it never goes away. And that's okay. That's normal. It's not supposed to go away. That's just capitalism that's told you that, or that expects that of you. Um, all right, everybody take a deep breath, please. That was a lot. So that is, in my experience, what the dying process looks like for most people in some way, shape, or form. That would be a very typical dying process, I guess, or a very typical trajectory towards end of life that I would see in a person. Please let me know what questions you have, or share what your experiences have been. Because I know a lot of people have experienced at least something that I talked about today. A lot of people have probably experienced or witnessed a lot of those things. And I feel like because death is so mystical in our culture and so secretive, and we don't want to see it, we don't want to talk about it, we don't want to allow people to die. So a lot of us haven't seen that often. So it seems really scary and unknown. And then what a disservice our culture does to us, because if we do finally witness what death actually looks like, it's usually someone that we love. The first dead body most of us see is somebody that we cared about. So not only does it seem unknown, we're not used to seeing it, but then our first experience is like, oh, it's my loved one. That's the first dead body I've ever seen. And that just does so much more damage than it needs to do. And that's not our fault. That's our culture's fault. And the patriarchy's fault and Christianity's fault. So don't hesitate to reach out for support or with your questions. I would really, really be interested to hear what kind of comments people have or experiences they've had in witnessing the death of a loved one, or what questions everybody has. So, proven paradox. I hope that explains the death rattle. Thank you for kindly calling me out on it. And I hope that this was an interesting episode for people. Hopefully DJ will be with us next time we're on. And in the meantime, you can reach out to us on Instagram at life_death_dirt. And that is the only place we are. Actually, hold on. Let me tell you one more thing. We also are, we have an email, and it is, hold on. You can also email us at lifeanddirtpod@gmail.com, all spelled out, LIFEANDDIRTPOD gmail.com. That is our email. And I will try to start regularly checking that. I finally just went through and read all the YouTube comments. I'm so sorry. We have not been ignoring you. I just didn't think anybody commented. And then I went back and realized that people have been commenting and giving us advice on the skunks and botulism, and then Proven Paradox called me out about the death rattle. So I apologize. I've not been ignoring you all. Thank you for the comments. So far, they've all been nice. I appreciate that. Keep it up. No mean comments. I can't handle it. I'm way too emotionally fragile right now. Only tell me the things I want to hear, please. Okay. Thank you so much, everyone. Take care. Be in touch. Keep on living, I guess.